Hi friends, my name is Dr. Kannan Kumar and I'm a consultant hand and upper extremity surgeon at Bangalore. And this is Plexus Ortho, and we're going to discuss today scapular fractures. Hopefully, in about 15 minutes, we can condense whatever you need to know about scapular fractures for your exams as well as for your future clinical practice as well. Start off the introduction. Scapular fractures are usually very high energy trauma. It's never an isolated injury. That is my experience, and it's missed many times. Right. So we look at the upper limb injuries and the rib fractures, and many times because the scapula is hidden behind the rib cage, we miss the scapular fracture many times. It is associated with neurovascular problems. So many times you have this scapular fracture with scapulothoracic dissociation. So we have a very high um, um, percentage of subclavian artery injury and a very high percentage of brachial plexus injuries as well. And one important thing about scapular fractures, most of these can be managed non-operatively. There are very few indications for surgery, which we will go through in this presentation, which will help you for your MS and DNB exams. And this sling, just a sling is enough in about 90% of the cases. When do you need surgical intervention? When there is a polytrauma, when there is a floating shoulder, that is an injury to the suspensory mechanism of the shoulder, when there are open injuries, and when there are intra-articular fractures. So these are some of the indications for surgical interventions. Today we're not going to be discussing coracoid or acromion fractures, which we will do in another video. So how do they present to us? They present to us by a direct blow. The patient falls directly on the scapula or on a fall on an outstretched hand, right? Foch, fall on an outstretched hand. That is the expansion of Foch. Don't forget that. Don't write that in your records or in your exam, but it is something that we use for communication. The symptoms that patient usually have is very severe shoulder pain, very severe chest pain, breathlessness because they may have pneumothorax and hemothorax associated rib fractures, and scapular fracture itself causes difficulty in breathing, that is inspiring and engaging the chest wall becomes more painful. So they have very severe pain disproportionate to the injury sometimes. You might also be able to see some kind of hematomas and clots over the skin, over the chest and upper arm regions. This is a very high energy trauma, so you should look first for other injuries which are life threatening, like abdominal, head injuries, etc. The first thing in scapular fracture management is ABC, that is airway, breathing, and circulation. The rest then comes the scapular fracture. So, scapular fracture is not the first priority in these injuries. What are the associated injuries? So, my experience and also literature says that almost 100% of the time there is an associated injury. It is never isolated. See, thoracic and rib injuries are very common. Rib injuries and thoracic injuries are seen in about 80% of the scapular fractures. Associated hemopneumothorax is also very common. And you have clavicle fractures in about 25% of patients. You have ipsilateral extremity fractures like the humerus fractures, elbow fractures, and forearm fractures. Sometimes you look at those fractures and we fail to pick up the scapular fracture. So, this also must be kept in mind. You have an associated spine fracture in 30% of cases, pelviacetabular fracture in 15% of cases, and vascular injuries are seen in 11% of cases, and brachial plexus injuries in 13% of cases. Right? So, vascular injuries and brachial plexus injuries are very important. So, we may lose the limb, right? It's called scapulothoracic dissociation. Vascular injuries are seen in about 11% of cases, and this must be kept in mind. Even though the upper limb has good collaterals as compared to the popliteal artery injury of the lower limb, we have to keep an eye out for the subclavian artery injury. So, whenever you have a scapular injury, look for scapulothoracic dissociation, look for vascular injury, subclavian artery injury, and look for brachial plexus and document it because this can cause medico legal issues later on. How do you image these injuries? So the imaging is done by first X-rays. You take a true AP view. All of us know how to take a true AP view. The plate must be kept against the chest wall posteriorly, and the beam is directed at 45 degrees so that the glenohumeral joint is made out well. This is called as a true AP view of the shoulder, right? Then we have the axillary view. Axillary view, I'm not going to go into the detail here. We all know how to take the axillary view. You abduct the shoulder and you keep the plate under the shoulder, and then you will be able to pass the beams from caudal to cephalad, and you should be able to get an axillary view. A Y scapular view also must be done, which all of us know how to do it. And then a Garshi view. Garshi view is done. So how do you do the Garshi view? The Garshi view is basically the plate is kept uh, Gracie view, not Garshi, it's the Gracie view. The plate is kept, or the plate the patient is about tilted 45 degrees anteriorly to the plate, and the beam is passed right through this. This is to see the glenoid in a better fashion, to see if the glenoid is broken, or there is an intra-articular step, or there is some displacement. So this is called as the Gracie view, Grashey. So it is called the Gracie view, where the patient is tilted from opposite shoulder, moves forward anteriorly in an angle of 40 degrees to the plate, and the rays are passed to the shoulder perpendicular, and this will give us a what is called as a Gracie view, which shows the glenoid in a better orientation. So you can also take what is called as a intra-articular to look at the intra-articular step. The best way to do that is through CT scans and 3D reconstruction of the CT scans. So 3D reconstruction is a must in most of these cases where you suspect a glenoid fracture. And some of the other parameters that you should see on X-rays and CT are what is called as a medialization or the lateral offset. So when the lateral border of the scapula is shifted laterally, right, by more than 2 centimeters, this is a good indication for surgery. That means it is highly displaced fracture. It's a highly displaced fracture, and this is a good indication for surgery. So you should do what is called as a medialization, or measure the lateral offset of the scapular body. And the next thing you should measure is called as a glenohumeral or glenopolar angle. So the glenopolar angle is you draw a line from the superior pole to the inferior pole of the glenoid, and then draw another line from the superior pole of the glenoid to the inferior pole of the scapular body. So this angle is called as a glenopolar angle. So anything less than 20 degrees is not anatomical, which indicates surgery. So anything more than 20 degrees, you don't have to operate on these. But anything less than 20 degrees, you have to operate on these, or is a relative indication for surgery in these cases. The next one that you have to see, next angulation or next radiological parameter that you have to see in scapular Y view is the scapular body angulation. So if the scapular body is the angle between when the body is fractured in the middle, and when the angulation of the lateral border of the scapula is more than 40 degrees, this is an indication or a relative indication for surgery. Right? There are many, as I've always said, I've already said, scapula is always managed most likely in a conservative fashion. Very rarely it is managed surgically, and these are some of the indications for surgical management. So more than 40 degrees of scapular lateral border angulation on a Y scapular view. Glenopolar angle of less than 20 degrees is an indication for surgery. Lateral offset or translation of the scaphoid fracture more than 2 centimeters is an indication for surgery. These are some of the radiological parameters that you should get to look for surgical intervention. Then most of these cases do require CT scan for better understanding of the intra-articular. If you can see here, there are 3 pieces here. There's one piece here, one piece here, and there's one piece here. So this is the anterior piece which is displaced anteriorly, posteriorly displaced posterior piece, and there's a small piece here. So there might be multiple pieces, and you can also see a GT fracture here. So a CT scan with 3D reconstruction gives us a better understanding of the fracture, and we have a better overall um, uh, view to go in and fix these fractures. Now, coming to the classification, there are multiple classifications available. I think for your exam purposes, Ida-Berg classification or ID-Berg classification is probably sufficient, right? In type 1 is the glenoid intra-articular fracture. In type 1A, it is an anterior fracture. In type 1B, it is a posterior fracture. In type 2, the fracture passes through the glenoid and exits inferiorly, right? In type 2, the fracture line exits inferiorly. In type 3, the fracture line exits superiorly. In type 3, the fracture line exits superiorly. In type 4, the glenoid fracture exits in the medial side, exits medially. And type 5 is a combination of any of the above. So Heidelberg classification is basically for intra-articular classification of glenoid fractures, right? So Heidelberg classification is intra-articular classification of glenoid fractures. Type 1, to reiterate, type 1 is a intra-articular fracture with type 1A being the anterior glenoid, type 1B being the posterior glenoid. In type 2, the fracture line passes inferiorly, type 3, the fracture line passes superiorly, type 4, the fracture passes medially, and in type 5 is a combination of the above four. Now, there's another concept we have to be sure of, because there's something called as a floating shoulder injury, which will be dealt in another video, right? So there's a suspensory ligament, which is a circle here, right? It includes the coracoclavicular ligaments, acromioclavicular ligament, acromion, spine of the scapula, and the glenoid. So if any of these structures or two or more structures is injured, then we say it is a double injury to the suspensory ligament, suspensory mechanism of the shoulder girdle, right? So when you have a double injury, for example, this is an acromioclavicular or acromia fracture plus scapular neck fracture. Here you can see a coracoclavicular ligament injury with a neck fracture, and here you can see a clavicle fracture with a neck fracture, and so on and so forth. There are multiple combinations available, and in this case, this is one of the relative indications to fix the scapula. So that is why we should have an understanding of this floating shoulder injury and its mechanism, which will be dealt in detail in another video. But you must understand this suspensory mechanism, or that suspensory bony ligamentous mechanism that is seen in the shoulder region or shoulder girdle. And if any two or more structures are involved, then it indicates a floating shoulder injury, and it has to be repaired or reconstructed. So now coming to treatment options available, most of these can be treated, more than 90% can be treated conservatively. The non-operative indications are when there is less translation, that is medial lateral translation of less than 1 centimeter, angulation of less than 40 degrees in the Y scapular view, angulation of the scapular body of less than 40 degrees in the Y scapular view, glenopolar angle of more than 90 degrees. So, excuse me, more than 20 degrees, glenopolar angle of more than 20 degrees injury, and no additional injury to the superior shoulder suspensory complex. Intra-articular fractures, anything less than 4 mm step off and less than 25% of glenoid involvement, can be managed conservatively. What are the operative indications? One, of course, in open fractures, as in any other fracture. Scapular body fractures, where there is a medialization of the lateral border by more than 2 centimeters. Glenopolar angle of less than 20 degrees. We have discussed all this, and with pictures. Angulation in the Y scapular view of more than 40 degrees, right? And in a scapular neck fracture, the same things, more than 40 degrees of angulation, more than 1 centimeter, and floating shoulder, where there is more than 2 injuries, you have to fix them. If it is an intra-articular fracture, more than 25% of the anterior or posterior glenoid, and an articular step off of more than 4 millimeters. So more than 4 millimeters of step off. It's not the 2 millimeter step off that you see in distal radius fractures. Rather, it is a more than 4 millimeter step off that is recommended to be fixed in glenoid fractures, and more than 25% involvement of the glenoid. So these are the two criteria on the basis of which you fix these glenoid fractures. What are the surgical approaches available? The surgical approaches available are a posterior approach or the anterior approach. The posterior approach, you have the modified Jude or Jude approach. The previously used Jude approach was by detaching the deltoid, but the new approach is by preserving the deltoid, and therefore it is called the modified Jude approach. You have the straight posterior approach, and for the anterior, where you have to approach the anterior glenoid or coracoid, you have to do the deltopectoral approach, which everybody is familiar with. We won't be discussing in this video. So the main approach for the posterior or most of the scapula, including the posterior part of the scapula and the scapular body and neck, is the modified Jude approach. So the modified Jude approach avoids detachment of the deltoid. It exposes the lateral column for us, the articular segment, that is a posterior glenoid, medial border, and the body. So first you make an incision, which is a reverse hockey stick, or you can say a L-shaped incision, which is made from the spine of the scapula and extending down to the medial border of the scapula. A thick skin flap is raised and flipped over this side to expose the underlying muscles and structures. Now here you have the neurovascular structures that we can encounter in this approach. So this is, all of you know, what is it? It is the spinoglenoid notch. Forgive me, this is a suprascapular notch which is superior, and the bottom one is the spinoglenoid notch. In the suprascapular notch, the suprascapular nerve comes in. What nerve does it supply? What muscles do the suprascapular nerve supply? Suprascapular nerve supplies the supraspinatus and infraspinatus muscles. The suprascapular nerve, as we all discussed in the brachial plexus video, they start from the upper trunk and they have contributions from C5 and C6 nerve roots, and they come and give supply to the suprascapular muscle here and the infraspinatus muscle here. Supraspinatus here and infraspinatus here. So when they reach the spinoglenoid notch at this level, the nerve is only the infraspinatus nerve, and it only supplies the infraspinatus, already given away the branch to the supraspinatus. Here we also have the teres minor in the inferior to the infraspinatus, and that is supplied by a branch of the twig of the axillary nerve. So the structures that we can come across are the suprascapular nerve, and most likely injured to be is the infraspinatus branch of the suprascapular nerve. We can also encounter, if you go very medially, the axillary nerve and the posterior circumflex humeral artery, and it can bleed quite a bit if it is injured. So you have to be very careful at that level. So once we make the skin incision and raise the flap, we can see the deltoid, and below here, above is the supraspinatus muscle, above the spine of scapula. Below is the infraspinatus muscle, and here is the teres minor, and here you can see the teres major muscle. So once the skin flap is raised and the deltoid is lifted up superiorly, we can see the infraspinatus and teres minor muscles. That is the internervous plane between which we go in. Then we raise the infraspinatus muscle, erase it from the medial side to the lateral side, and we can expose the whole of the scapular body and the glenoid in this approach. The other approach that can be, or limited, minimally invasive approach that many people have been advocating, is the Brodsky or the lateral column approach, where a single incision is made on the lateral column to approach fractures of the glenoid, posterior glenoid, and the lateral body, and probably the scapular central body as well. Very difficult to access the medial body with this approach. So here the incision is basically a straight incision along the lateral border of the scapula. In a similar way, you raise the deltoid superiorly retracted between the infraspinatus here. This is the infraspinatus and the teres minor here. You go in between these two, and then you get an access to the posterior glenoid. Capsule and posterior glenoid can be seen here, and you can here fix plate on the, or fix the fracture of the lateral column or the scapular body. So the same as approach you can access between the supraspinatus above, infraspinatus below. We can approach the glenoid, posterior glenoid and capsule as well, and this is an approach to the lateral column of the, or lateral part of the scapula. And this is an illustration showing the same thing. The stitch has been applied on the capsule. Using retractors, you retract and open up, and we can see the posterior glenoid in this approach. So these are some operative pictures which may not be as good as illustrations, but just to show you, this is the modified Jude approach, where the incision is made along the spine of the scapula, extending to the medial border of the scapula. Here the skin flap is raised, then you erase the infraspinatus muscle, and you can expose, this infraspinatus muscle is erased from medial to laterally, and you can see here the fracture, which is very clear and obvious and can be easily seen. The other approach is the minimally invasive lateral border approach, where you access various parts of the scapula in the internervous plane between the infraspinatus and teres minor here, right? And infraspinatus is supplied by the suprascapular nerve, and teres minor is supplied by the by a branch of the axillary nerve. So what are some tips and tricks to fix the scapular fracture? Of course, these are very flat bones. These are very thin bones, sometimes very difficult to fix with conventional implants and screws and plates that are available with us. So nowadays we have special screws and plates and implants available. We have to use all kinds of mechanisms to fix these fracture, including lamina spreaders here to reduce the fracture, using bone hooks, Schanz pins, taps, and clamps, different types of clamps and external fixators to try and reduce the fracture in which way possible. There are various implants available now. commercially available. A lot of Indian companies have also started making them. So you have to tell the company that you want an implant of this type, right? So you need to ask for these implants specifically. They'll give you all this in the set, and you can use this. This is, for example, for the acromion fixation. This is for the medial and superior border fixation, and this is for the lateral border fixation. So various kinds of implants are available to fix these, and from various companies, but all of them are useful now to and have made our life much easier to fix these implants. So let us take up an example. This is a scaphoid. This is a scapular fracture through the neck of the scapula, right? But it is not intra-articular, so this is not does not come under Heidelberg classification. You can see that the inferior scapular fracture is displaced about more than 2 centimeters laterally. So this is a relative indication or a good indication for surgery. This is a glenopolar angle. In this case, the glenopolar angle is about 30 degrees maybe. So this is, in this case, the glenopolar angle is more than 20 degrees, and this is not an indication for surgery. So what are the indications for surgery that we have? More than 1 centimeter or 1 centimeter lateralization of the inferior fragment, lateral offset of the inferior fragment, less than 20 degrees of glenopolar angulation, more than 25% involvement of the glenoid in case of intra-articular fractures, more than 4 millimeter step off in case of intra-articular fractures of the glenoid, and more than two structures injured in floating shoulder type of injuries. Floating shoulder type of injuries. These are the relative indications for surgery. This one must keep in mind when we're writing this answer in the exam. Suppose an examiner shows this in your Viva VOC or OSCE as well, you can do the same thing. And you can also use this criteria, for example, if the patient presents to you in your private practice once you finish your courses. So please keep this in mind when you answer these questions related to scapular fractures. So here we chose to fix these fractures with recon plate. If you can see, when we can modify the recon plate to fix this fracture, you can see the scapular offset is restored. The glenopolar angle is good, right? So we had to fix the medial side and the lateral side as well. So we have used two plates. And patient also had a clavicle fracture, which was not fixed, probably went on to unite very well. So to conclude, right, scapular fractures, most of them are fixed. Most of them are managed conservatively. There are relative indications to fix. We've already discussed the indications in detail. And you must be aware of the other injuries that are associated with scapular fractures. Be sure of subclavian artery injury, and immediate referral to the vascular surgeon and opinion must be taken. Brachial plexus injury must be examined and looked for specifically in these conditions. So what are the problems that we can have once we fix this or manage this? One is you can have glenohumeral arthritis if there is a significant step off intraoperatively, intra-articularly. Malunion of the scapula can cause issues, right? If you have a more than 40-degree angulation, the scapula will not move smoothly on the chest wall and may cause malunion issues. We can have recurrent glenohumeral instability if there is an associated ligament problem, or if the anterior glenoid injury is so big that it can cause recurrent dislocations as well. We'll keep coming up with more videos, and hopefully this helps. Thank you very much. This is Dr. Kannan from Plexus Ortho. Thank you.